With a patient in the beach chair position, place a bolster between the shoulder blades and head, allowing the injured shoulder girdle to retract posteriorly. Alternatively, the patient may be positioned flat in the center of the table. This positioning may avoid fluoroscopy imaging disturbances from the bed itself or potential contamination of the surgical field. In either position, the bolster will facilitate reduction by bringing the clavicle anterior to restore length and improve exposure. Make a 3 cm vertical incision parallel to Langer's lines over the distal end of the medial fragment. Incise the deltotrapezial fascia horizontally to expose the fracture fragments. Some patients may have a very small medullary canal. In this instance, it is important to make a determination whether the diameter of the patient's anatomy will allow for an intramedullary implant. Place a spinal needle into the posterior AC joint. This will provide an aiming point to optimize screw purchase in the lateral fragment and reassure the surgeon that the instrumentation does not exit the clavicle into the AC joint. Under fluoroscopy, to ensure instrumentation maintains the correct path, hold the lateral fragment with serrated forceps and from the fracture site, use a 2.8 mm drill to open up the canal. Ensure that the drill does not exit the bone. Once the canal in the lateral fragment is opened up, use a serrated forceps to hold the medial fragment, and again from the fracture site, open up the canal with a 2.8 mm drill. Again, make sure not to exit the bone when using the drill. Insert the 3 mm T-handle reamer into the lateral fragment from the fracture site and ream in a medial to lateral direction, making sure not to exit the bone. If the reamer is engaging cortex, it indicates that a 3 mm diameter dual track clavicle screw, along with accompanying 3 mm instrumentation, should be used through the remainder of the surgery. If the reamer is not fully engaging the cortex, use the 3.8 mm T-handle reamer to prepare the canal. In this instance, a 3.8 mm diameter dual-track clavicle screw, along with the accompanying 3.8 mm instrumentation, should be used to achieve fracture fixation. Make note of the reamer length inserted into the lateral fragment. This measurement can be used in Step 3 to help determine the length of the dual-track clavicle screw to be implanted. Next, hold the medial fragment with serrated forceps and insert the 3 mm T-handle reamer into the medial fragment canal and ream in a lateral to medial direction, making sure not to exit the bone. If in Step 2 it was determined that a 3.8 mm diameter implant and instrumentation would be used, then the 3.8 mm reamer should additionally be used on the medial fragment. Similar to Step 2, make note of the reamer length inserted into the medial fragment. To determine screw length, add the 2 reamed depth measurements in Steps 2 and 3 to establish the final implant length. Note: if the 2 measurements added together are less than 80 mm in length, the patient may be an incorrect candidate for intramedullary fixation. In this instance, the patient may be a better candidate for the Acumed clavicle plating system. Next, chuck the clavicle tap drill by the blunt tip nose just past the tap threads. Insert the trocar tip portion of the tap drill into the lateral fragment. Drill forward in a medial to lateral direction, advancing the drill through the posterior cortex of the clavicle. Upon tenting of the skin, make a stab incision and advance the drill out of the skin laterally, making sure to protect soft tissue until the threads begin to engage the lateral fragment. Unchuck the tap drill from the tap end and re-chuck laterally over the exposed tap drill on the section with tri-flat contours. Reverse the tap drill laterally until the threaded portion is completely within the lateral fragment. Reduce the fracture and under fluoroscopy, advance the tap drill forward into the medial fragment to the desired placement. Stop tapping prior to exiting the bone. We recommend that the entire length of the tap threads engage the medial fragment. Remove the chuck while keeping the tap drill in place, as this will serve to maintain reduction until after Step 7. Select the correct left or right specific cannula and slide it over the exposed portion of the tap drill. Rotate the cannula so the nose is flush with the bone. Connect the cannulated clavicle step drill to the Hudson Connect adapter on the ratcheting driver handle. Insert over the tap drill and through the cannula. Use the step drill with the ratcheting driver handle to open the entry site of the clavicle. Note: the dual track offers the surgeon the ability to achieve up to 3 millimeters of compression, as well as the ability to implant the device flush to the cortical surface or buried up to 5 millimeters. This technique will follow steps to achieve 3 millimeters compression and implant the device flush to the cortical surface. With a cannula flush to the bone, advance the step drill by hand in a lateral to medial direction until the first groove on the step drill aligns with the back of the cannula. The second groove is used in the instance that reduced compression is preferred. Note that the step drill has a built-in window for screw measurement. To determine the proper screw length with the first groove even with the end of the cannula, make note of the laser mark measure on the tap drill with the laser marks on the step drill. This will confirm the proper length of dual track clavicle screw to be implanted. If the length is between sizes, downsize to the shorter screw length. Also note, on the tap drill, the measurement for 70 millimeters is replaced by a double line. Visualizing this double line through the window in the step drill is an indication that you've reached the limit of drilling depth. If this occurs, advancing the drill further risks the possibility of binding the step drill on the threads of the tap drill. Stop and back out the step drill. Reaching this point indicates that the patient may be too small-boned for an intramedullary device and is a better candidate to use the Acumed clavicle plating system. Remove the step drill from the medullary canal. Rechuck the tap drill on the tri-flats and reverse out through the lateral entry point. Place the insertion tool through the lateral fragment from the fracture site in a medial to lateral direction, so it advances out of the lateral end of the clavicle and skin. This aids in identifying the implant entry site and eases the process of inserting the dual track screw into the medullary canal. Place the nose of the dual track screw into the concave portion of the insertion tool. Through the cannula, thread the dual track screw into the medullary canal while withdrawing the insertion tool. As the screw approaches the fracture site, remove the insertion tool, reduce the fracture, and advance the dual track screw into the medial fragment. With a cannula flush to the bone, advance the dual track screw until the first groove on the hex driver is flush with the back of the cannula. This will indicate that the device is flush with the cortical surface and the maximum compression of 3 millimeters